So where have we gotten in developing this care plan? One of the things I think we've landed on as being most critical is making sure the patient voice is reflected both in the development of the care plan and in how it's used. So we're currently conducting formative interviews with patients to capture what their preferences are going to be in terms of what they want to see in the care plan. And then once we have something to actually look at, right now it's just a massive spreadsheet that nobody wants to look at. It'll make you dizzy, I swear. Once we have something a little more concrete to look at, we'll have some evaluative interviews as well. And we also want to make sure patients are able to participate in the use of the care plan. So we're hoping to integrate, just as we would with an electronic health record, to integrate the care plan with personal health records and patient portals. And that way, we would enable real-time patient input and feedback on important issues like their goals and priorities and perceptions of care. Another direction that we've found important is making sure the usability is functional for all of the target groups. So in order to be functional, and this kind of gets to that challenge of brevity versus comprehensiveness that I alluded to earlier, in order to be functional, we need to have the same set of data traveling from place to place, because if you don't have the same set of data going from place to place, you'll lose consistency. You'll get version control, all kinds of issues. But not every user is necessarily going to want to look at the same set of data. For example, nutrition goals are probably going to be really high priority for a dietitian, but they might be lower priority for the nephrologist. Not to say that's the case for every nephrologist, but just in general. So what we're hoping to do is make sure there are individualized displays for the care plan. So all the priority data will be there, but when a nephrologist logs in, he'll see a screen that's kind of geared towards the nephrologist. When a dietitian looks at the care plan, he or she will see a screen that reflects what information is important to them, and same goes for a patient. But importantly, we recognize everybody has different preferences in terms of the information they want to see. So we'll allow users also to personalize their display. So if that nephrologist was really interested in diet, he or she could go and make sure nutrition goals were reflected when he pulled up or she pulled up the care plan. In terms of coding the care plan, we recognize we need to go beyond administrative or billing data or codes. As Dr. Shahinian mentioned, a lot of the codes that are used in the EHR were originally developed for billing and not for care. And so they often are centered around information. So unless you give a diagnosis or if you run a test, you can see that, but you can't necessarily see what the test results were all the time. So we need the systems to be able to be searchable by test results, not just if or when the test was conducted or when the diagnosis was made. And so we're going to be including laboratory and clinical codes. So LOINC is a common laboratory coding system, and SNOMED CT is a common clinical coding system that give you a little bit more of that depth of information. And then again, we're developing systems for capturing elements that don't have existing standards like CKD education, working with standard-setting organizations like LOINC to do that. We also hope to test the care plan and validate it to make sure it works. And as I mentioned, ONC is very excited because we're sort of in this void of where there aren't a lot of care plans that have been developed, and care planning is actually part of ONC's strategic plan, so they're very interested in seeing this work. And so we've got interest from insurance providers, EHR vendors, and health systems in helping to test this on a volunteer basis. I should mention that everybody involved in these working groups, this is all volunteer work too, so it's great to see it moving along. But importantly, we want to make sure that the care plan is feasible. So there's already been some feasibility testing of the care plan, not in CKD, but the care plan concept in general, to see if you can get it to move around the system like it should. But we also want to test the usability for providers and patients to make sure it's functional. So moving on to our phenotype working group, the goal here is to develop and validate an electronic CKD phenotype, along with implementation resources that will facilitate quality improvement, research, and surveillance of CKD. So what is a computable phenotype? It's basically, there's a definition I put up here from Duke that's pretty technical, so I'm not going to read that one. Instead, I'm just going to say that basically a computable phenotype for a disease is a set of codes that you can put into your EHR, and then your EHR will spit back out everybody who has that disease. And if only it were that simple. So there are certainly some challenges. Again, Dr. Shahinian alluded to some of these in terms of developing a computable phenotype. A lot of the challenges are similar to those with surveillance. This is a phenotype is really how you would use an electronic health record or health IT systems to do surveillance. So again, race is often missing from the EHR, which makes it race is needed to estimate GFR. It's part of the equation. Inconsistencies in estimating equations over time and across sites create challenges with aggregating the data. So like I mentioned before, the MDRD equation and the CKD-EPI equation give you slightly different results. And so you won't have consistency if one site or one lab is using MDRD and one lab's using CKD-EPI. Sites have also previously transitioned to what we call the IDMS traceable version of the MDRD equation, which is just a slightly improved equation, but the numbers again change over that transition. And again, some labs use MDRD, others use CKD-EPI. There's also an issue of determining albuminuria. So going beyond the fact that most patients don't have any albuminuria data, particularly, I should say, patients at risk, a lot of patients at risk who should have albuminuria data don't have it. Even the ones who do have it, a lot of it is what we call a urine albumin dipstick, which is less accurate than the urine albumin to creatinine ratio. So, but the dipstick is much more, so because it's more commonly available in the EHR, we don't want to exclude those people who may have albuminuria, which, obviously which is a sign of kidney damage. And if we limit our phenotype definition to UACR, we're going to be missing a bunch of people who actually do have signs of kidney disease. So, based on some of these challenges, the phenotype group actually slightly refined its purpose to say that what we want to do is identify a candidate group of patients likely to have CKD. Kind of sets the standard a little lower, broadens the sensitivity, lowers the specificity of the findings. But in terms of most health systems being able to find patients who are at risk and need care, we felt like this was the best way to approach it. Again, we're still hoping to provide tools and instructions for IT departments in order to facilitate population health management, surveillance, and research. And so basically, in summary, what we're trying to do is get the clinical team you see over here to your left who have varying interests in health IT, some very interested, some maybe struggling with it a little bit, turning their back on it, if you will, and our IT folks who are over on the other side of this chasm, giving them essentially the tools and instructions that they need to be able to bring their expertise together to find the patients in their system who have chronic kidney disease. So what the group has decided to do is to identify GFR by LOINC codes with the most recent value of less than 60 and at least one value less than 60 more than 90 days prior. And that gets to the chronicity issue that Dr. Shahinian alluded to earlier. The reason why we feel this is so important is if you look for just one value less than 60, you'll be getting a bunch of people who had acute kidney injury, which is a different, so that's that one-time lower in GFR rather than the long-term lowering. Alternatively, if a site wanted to get a higher risk population, they could change that cutoff to 45 to target a group more likely to progress or to be closer to ESRD at any rate. We recommend that for the majority of sites, they use the GFR reported by the lab, regardless of whether it's MDRD or CKD-EPI. Again, we recognize that brings in a sort of an added variable, but because these equations are estimates anyway, I don't know if most folks in the room know, there's, see if I can get this right, for both MDRD and CKD-EPI equations, there's about an 80 to 90% chance that the equation will give you a result that's within 30% of the patient's actual GFR. So there's a lot of uncertainty built into the equations themselves to begin with. And so if you're really just trying to identify a group of patients who probably have CKD or at least are probably high risk for CKD and make sure they're getting appropriate care, make sure they're getting additional screening. The group felt that it's probably not so critical to distinguish at this point between MDRD or CKD-EPI. However, if you're a site who's interested in being a little bit more precise, or you could use creatinine to recalculate the GFR using a specified equation. And then in terms of dealing with missing race, the recommendation would be that each organization determine the method based on local demographics. So if you assume everybody in your population is Black, it will give you a less sensitive, more specific result. And if you assume everyone is white, it will give you a more sensitive, less specific result. In terms of albuminuria, similar definition identified by LOINC codes. Most recent value positive with at least one positive value more than 90 days prior. Cutoffs for urine albumin to creatinine ratio would be greater than 30 milligrams per gram. And for the dipstick, which we do want to include, because again, we don't want to leave out all those people who do have albuminuria, but we don't know exactly what their level is. We're actually in the process of conducting analyses across 5 sites to try to see if we can get a better sense of how those two tests align. So within people who have had a dipstick and a UACR measurement at the same time, we're going to be looking at the distribution of the UACR across the dipstick categories. So when you get a dipstick result, it comes in negative, trace, 1+, so on. So if we can kind of line those up, it will give us a better sense of what dipstick results we should be including in our population. And we'll be doing similar tests with urine protein to creatinine ratio, and then also comparing urine albumin and urine protein creatinine ratios. We also hope to validate the phenotype, so we'll be doing this across 4 to 5 settings, with the primary objective being determination of accuracy, again, that sensitivity and specificity of the phenotype, and secondarily to see how feasible it is for sites to actually implement this. What kind of challenges do they encounter, and what kind of resources do they need? And lastly, the working group is also trying to compile and prioritize pre-existing validated phenotypes. So as you might imagine, once you've identified this population in your setting who has chronic kidney disease, you may also want to identify people who have high blood pressure on top of that, or diabetes on top of that. And there are actually existing phenotypes out there for many of these relevant complications. There are a few that we're still seeking, so if anybody knows of any of the ones in red, please let me know. And lastly, I'll just spend a couple minutes on our business case working group. Again, the goal here is to create a framework business case that will allow individual settings to justify investment in infrastructure to support CKD population management. Sorry, my image got overlapped a little there. And I found this little doodle on Google. I don't know who to credit to. I couldn't find a source, but I really like the graphic because it actually shows how complicated a business case really is. Quite naively, when we first started these projects, I thought the business case was going to be the easiest of the 3, but I was wrong. And so there's really a lot that goes into it, and unfortunately, there's not a lot of data particularly related to CKD costs, particularly prior to end-stage renal disease. There's challenges also in identifying specific costs and benefits of population health management interventions. So we know that ACEs and ARBs really do help patients slow progression from CKD to ESRD, but we don't know exactly what % of patients will be slowed by what amount and what time period. And to get a business case to be accurate, you really need to kind of know that level of detail. It's also another challenge is the specifics of the business case will vary from institution to institution depending on the payment models and the CKD population. So depending on what type of payment model you use, the incentives for CKD care change. So who benefits from the improved care, who's going to save money, can be different across different institutions. And then across the healthcare setting, there's a shift in financial incentives as many sites are transitioning from traditional to alternative payment models. So just in summary, Health IT has promise to improve CKD detection, management, and research, but there are still many challenges that need to be overcome. And the projects we're working on, the care plan and the computable phenotype and the business case, we hope will start to address some of these challenges. And I'd just like to really briefly acknowledge the working group members. So our Health IT working group led by Paul Draws out of University of Minnesota. Our care plan working group led by Teresa Cullen at the Regenstrief Institute and Andrew Narva at NIDDK. Our phenotyping working group, again led by Paul Draws, along with Ken Kawamoto at Utah. And our business case working group led by Blake Cameron at Duke University. And if I didn't use up all of my time talking, I'm happy to take any questions.
We have time for one question.
Sorry.
You're the one lucky.
Hi, thank you for your talk. It was very interesting. I'm doing my PhD in computer science, and I'm working with Dr. Cherkovitz. I had a question regarding the phenotype model that you spoke. So when you find out patients who are similar to other patients using the phenotype model, I wanted you to shed a little bit of light on, are you using any specific algorithms, or is it more like just filtering the data, as in based on the measurements, race or gender and other things?
So the phenotype will, let me make sure I'm getting your question. So you're saying in addition to GFR and albuminuria, are we including any other metrics in the phenotype?
Yeah, and also for GFR and other measurements that you're using, do you have a range by which you're calling patients similar, or how are you calling patients similar? How are you filtering out patients who are similar to each other, or how are you determining the phenotype among patients?
Basically, the phenotype is basically, it's just designed to allow somebody to go into their electronic health record and pull out everybody who has chronic kidney disease or who's likely to have chronic kidney disease. As I mentioned, it's probably prohibitive for most sites to be super accurate. But if you can get that population that's likely to have CKD, you can make sure they're getting appropriate care, make sure they're being looked at. I'm not sure I'm fully answering your question. So I think there's not necessarily parsing within that, although we are hoping to provide those additional phenotypes that I referenced briefly, so that you could find people within that CKD cohort who have high blood pressure or other conditions. If race data is available in your electronic health record, you could then go back in and parse by race. But as we mentioned, it's not always in there. So, I mean, once you have the phenotype in there, you could go back through and do further parsing along any variables that you want, but it's not included in the original phenotype. Is that what you were asking? Okay.